Inflammation is part of the innate immune system, which is the evolutionarily best conserved component of the immune system, which is largely driven by the natural selection of different genetic components. This has been shaped through evolutionary time by the contact that our ancestors had with their own environment. And therefore, might be, who knows. So because of this prolonged natural selection, key mechanisms have been selected to fight common pathogens in the environment. The innate immune system is made of a number of different elements, which include body physical barriers, such as the skin and the gastrointestinal tract. These are things that separate from what is inside the body from what is outside the body. We then have non-self-recognition elements, such as the complement and tool-like receptors and others. And these are elements that are essential to recognize what comes from outside the body that needs to be recognized to then trigger an activation. And we have, as you can see there, cytokines and endothelial cells and other cells that contributes to the activation of the inflammatory response. And as a consequence of the activation of the inflammatory response, we then have the last set of elements, including phagocytes and acute phase proteins, that really drive the response and protect the body from infections. And when, in fact, we do have wounds and traumas, physical traumas this time, what inflammation does is really the essential vital response to prevent the spread of infection and also to promote tissue repair. And what I will do today is to focus on some of these response elements that you see at the bottom there for two main reasons. One is that, as you see, this is the end of a cascade of events. So by measuring these response elements, we can have an idea of how much this cascade has been activated. The second factor is that these response elements can be comparatively easily measured in the blood. So what happens is that the activation leads to the secretion from the liver of some of the acute phase proteins I was telling you about. So, for example, C-reactive protein and fibrinogen, which we will discuss in a minute. And these then are released in the circulatory system and go into the place where we have wounds and infections to try and fight these infections. So this is what we mean by inflammation, but why should we care about inflammation if, for example, we try to treat and understand the pathophysiology of depression? Well, for a number of reasons. From a molecular point of view, there are several theories. This is one of the top theories that have been developed over the past few years, both from research in animal models and humans. What you see on the top is tryptophan, which you know is one of the key components that allow us to generate and produce serotonin. Serotonin is essential as a neurotransmitter, is involved in a number of different functions, but is essential in mood regulation. So much so that the main class of medications that we use to treat depression, SSRIs, so selective serotonin reuptake inhibitors, try to target the levels of serotonin in the synapse. What happens in condition of systemic inflammation? You see here interferon gamma and TNF-alpha. These are pro-inflammatory cytokines, some of the activation elements I was telling you about. What happens when these elements are high is that these cytokines stimulate an enzyme called indolamine deoxygenase. And what this enzyme does is taking tryptophan from the synthesis of serotonin on your right-hand side into an alternative path that goes down to build kynurenine and also to stimulate eventually the NMDA receptor, causing excitotoxicity. So you see here that just by this mechanism, in condition of systemic inflammation, we are more likely to have lower levels of serotonin and increased stimulation of NMDA receptors, so exotoxicity. There are then a number of other mechanisms that I will not go into right now that also contribute to the effect of inflammation on depression, but also on a range of other psychiatric conditions. So if inflammation is really so important in the pathophysiology of depression, we would expect that inflammation levels are then higher in patients with depression compared to patients without depression or to healthy controls. And this is one of a few meta-analyses that have looked at this very question. And what you can see here are just effect sizes showing that there is indeed an increase in the plasma level, in the blood level, of some of the key inflammatory biomarkers, including C-reactive protein, interleukin-6, IL-1, and IL-1RA. This is correlational evidence. So it's still possible that although inflammation levels are high in depression, it may not be that inflammation leads to depression, but the other way around, that depression perhaps, because it's associated with stress, leads to high levels of inflammation. So it's important also to have experimental studies, both in animal models and in humans, that clarify the direction of this association. And out of a few, I thought to show you this study was one of the first ones, showing how a pro-inflammatory cytokines that has actually been used clinically, to treat different types of cancer, for example, can induce effectively experimentally depression. So these were all individuals who, at the beginning of the study, here on the left-hand side, were free of depression, but had a diagnosis of malignant melanoma. And what you can see is that by starting them on interferon alpha, there is a progressive increase in the risk of depression, or what you can see here better is the reduction in the number of people free of a diagnosis of depression over time. What you can see is that this is particularly true in patients that receive placebo, but is particularly, partly moderated by the administration of an SSRI, in this case paroxetine, suggesting that if we can compensate some of the biological pathways through which inflammation leads to depression, as I was telling you, and we focus, for example, and we target the serotonergic system, we might be able to reduce the inflammatory-induced risk of depression. So this is a set of observation showing how inflammation might be relevant to the pathophysiology of depression. But why would we be interested at all in looking at whether maltreatment is then associated with inflammation? Well, in addition to infection and tissue damage that I was telling you about, the inflammatory response can also be triggered by psychosocial stress, both acute and chronic psychosocial stress. So what you can see here in this graph is that the effect of stress on the brain brings about a series of effects. And in particular, if you focus here on the left-hand side component, you see that exposure to stress triggers the activation of the sympathetic nervous system. This is part of the peripheral nervous system, and that leads to the activation of the inflammatory response. People have theorized that this stress-induced activation of inflammation, of the inflammatory response, may be an evolutionary conserved mechanism through which exposure to psychosocial stress prepares our body to face tissue damage and infections should tissue damage actually occur. However, particularly in our days, quite often we feel stress, we are stressed, but we don't really endure physical damage. And it's very important to switch inflammation off, because as much as it is powerful to destroy common pathogens in the environment, it is a non-specific type of response. So it also acts inside our body and targets some of our own body, for example, contributing to cardiovascular disease, diabetes, potentially dementia. So some of the outcomes that we just discussed in terms of the long-term effects of maltreatment. And in fact, we have redundant paths that can inhibit inflammation. One is the activation of the parasympathetic nervous system, the other branch of the peripheral nervous system. And the other one is the hypothalamic pituitary adrenal axis with the secretion of glucocorticoids, so cortisol in humans. And this is really the most powerful anti-inflammatory compounds we have in the body, but also we use in the clinic to treat inflammatory conditions. So a few years ago, Christine Heim and others have shown that adults, particularly with a history of childhood maltreatment, have impairment in this path that is the hypothalamic pituitary adrenal axis, potentially because of relative resistance of the receptor of glucocorticoids to the effect of the hormone itself. So although we might have normal levels of the hormone or even higher level of the hormones, as we might hear later in the day, these high levels of the hormone don't translate into increased effects of the hormone. And therefore, because of effectively a functional lack of anti-inflammatory pathways, I started thinking that perhaps adults with a history of childhood maltreatment might have had a high level of inflammation. And to address these questions, I started really my collaboration with the Dunedin Multidisciplinary Health and Development Study, which is a life course study that was started in Dunedin, New Zealand in 1972-73, with 1,000 births that have been followed up over their life course. The analysis I will be focusing on today are at the follow-up at age 32, and we have now also completed the age 38 assessment. And what I will discuss is the direct association between childhood maltreatment, which I will tell you about in a minute, and a number of clinically relevant biomarkers of inflammation, including C-reactive protein, fibrinogen, and white blood cell counts. So these are all indicators of inflammation that GPs and various doctors use on a daily basis to predict the risk of different conditions. So in terms of childhood maltreatment, because of the prospective longitudinal design in the study, we were able to prospectively measure a number of experiences in childhood. So this is a composite measure of experiences between the age of 3 and 11, including maternal rejection that was measured when children, study members age 3, by a clinical psychologist observing the relationship between moms and the children. Harsh discipline based on parenting questionnaires when children, I believe, were aged 5 and 7. And out of the sample-wide distribution, I then took the top decile to identify those that, in that context and at that time, were particularly harsh to their children. These roughly caregiver changes, so these are changes, repeated changes in primary caregivers, mainly led by child protection concerns. And then reports of physical abuse and sexual abuse that are actually retrospective in nature. They were done by study members when they were aged 26. And although retrospective in nature, are before we measure our outcomes of inflammation, so are less likely to bias the results. And if we look at the cumulative prevalence of these experiences, you see that 3 out of 10 study members experienced one of these experiences, and 1 out of 10 study members experienced 2 or more. And what I will show you are these results based on this category of no probable or definite maltreatment. So the first question really was to look at the association between maltreatment and a key risk factor for later disease, which is a categorical measure of C-reactive protein greater than 3 milligrams per liter, which has been endorsed by the CDC and the American Heart Association. And what you can see here is that the severity of exposure to maltreatment is associated with the risk, the proportion of the study participant with high levels of inflammation. So you see there is a graded and significant association between exposure to maltreatment and inflammation. In other words, those with the maltreatment exposure, particularly the definite maltreatment exposure, so the more extreme, were almost twice as likely to have these high levels of inflammation later on in life. However, you will quickly realize this is a long-term association between something that happened in childhood and something that we then measured in adult life. So we took interest in testing alternative hypotheses that could have explained these associations based on literature findings. So one of the key hypotheses is that, of course, maltreated children live in a cluster, experience a cluster of risk factors, including particularly low socioeconomic status and also low IQ. And I observed that these risk factors are independently associated with inflammation later on in life. So it was possible that it was not maltreatment having this effect on inflammation later on in life, but these other factors that are correlated with both that could offer alternative explanation. However, even after statistically adjusting for this alternative hypothesis, the association between maltreatment and inflammation remains significant. Similarly, maltreated children are more likely to experience stress, depression in adult life, and also to live in disadvantaged socioeconomic conditions. These are not childhood variables, these are adult variables, so they're not alternative explanation, but could highlight how maltreated children might develop high levels of inflammation. Similarly, you see that depression and perceived stress are independent predictors of inflammation. But even when adjusting for these factors, maltreatment still predicted inflammation. And finally, maltreated children are more likely, as we have heard earlier this morning, to have different cardiovascular risk clusters. So this, for example, shows you that maltreated children are more likely to develop what is generally called metabolic syndrome. They're more likely to smoke as adults. And some of these factors, again, independently predict inflammation. However, even after accounting for these variables, and even in complex models that adjust for all these hypotheses together, there was a significant relationship between maltreatment and inflammation. A parallel question is whether or not this association only relies on one measure of inflammation or could be generalized to other measures of inflammation. So what you see here is not a categorical, but a continuous measure of inflammation. That is, we're not asking whether or not they have high levels of inflammation, but we're asking how much inflammation they have practically. And you see, again, we have similar association. We had other biomarkers of inflammation, as I said, fibrinogen and white blood cells. And using these other biomarkers of inflammation, we had similar results, suggesting that the association was not sensitive to a specific measure. And finally, putting together the variance of all these three biomarkers in one factor, which we calculated statistically as principal component analysis, you can see here that even with this more specific and precise measure of inflammation, we still find a significant and graded association between maltreatment and inflammation. So briefly, what we have seen is that maltreatment can identify individuals in the population who have high levels of inflammation. However, our focus was not just on inflammation, but trying to understand how inflammation might play a role in depression, and particularly in the type of depression that is associated with maltreatment. So in the next set of slides, I will show you from the same study, a slightly different study, slightly different set of results that take advantage of four groups of individuals. Those who did not have a history of maltreatment or depression, so the controls, as you can see on your left-hand side. Those who only had depression but not maltreatment. Those who had maltreatment but not depression. And those who had both. What we found is that those individuals who only have depression had only a non-significant increase in inflammation levels, so only a small increase in inflammation level. This is looking at C-reactive protein again. However, those with a history of maltreatment, and to an even greater extent, those with maltreatment and depression, had significant elevation in inflammation levels, particularly suggesting that maltreatment not only identifies individuals with high levels of inflammation in the general population, but may have similar value to identify patients with depression who have these high levels of inflammation. And similar findings were also observed for other biomarkers of inflammation. So just summarizing this first set of results, what we have seen is that maltreated children show stress-related elevation in inflammation levels. And in follow-up studies, we have observed that this increase is probably already starting in childhood. However, as was mentioned before, this is really, at the moment, for what I just described, merely a biological phenomenon. But it's really unclear at this point whether or not there is any clinical implication that follows from this. So to look at whether or not this might be of clinical relevance, I started thinking about depression, and particularly about the course of depression. And I started from these two very, very basic numbers about depression. This is the prevalence of depression. The yearly prevalence, or 12-month prevalence of depression, that is 7%. And the lifetime prevalence of depression, that is 16%. Different study will give you slightly different estimates, but that's, I think, rough and reliable estimate. So what these two basic numbers tell you is that the lifetime prevalence of depression is only about twice as much as the yearly prevalence of depression. What this tells you, in turn, is that depression is a recurrent type of illness, because all the different episodes that contribute to the lifetime prevalence of depression are likely to come from the same group of people. Yeah? So the true probabilities are not independent. And this is also backed up by the clinical observation that 60% of remitted patients will have recurrence in 5 years, and the growing evidence that each new episode of depression increases the risk of recurrence and also reduces the time to recurrence, so the time free of disease, leading us to think that depression is a recurrent and potentially progressive type of illness. This is important because it also suggests that what we need to do to prevent the largest burden related to depression is to identify that group of people who go on and develop recurrent types of depression. This was very interesting in the context of what I just told you, because not all types of depression are the same in terms of the association with inflammation. What you see here is a large American study showing that single episodes of depression, so individuals with single episodes of depression don't really have an increase in inflammation levels, but those with a history of multiple recurrent episodes of depression do, as you can see. So my reasoning was that if maltreatment is associated with inflammation, and if inflammation is associated with this recurrent subtype of depression, then perhaps maltreatment was also related to this subtype of depression. So what we set up doing was a meta-analysis of different studies, different epidemiological studies, that have looked at not at the risk of depression in maltreated individuals, but at the course of depression in maltreated individuals, particularly looking at the course, at the recurrence and the persistence of the illness. And this is the result. So let me walk you through it. So you will see the blue boxes. The blue boxes are the effect sizes from each individual study. So these are the results from each of the studies included in the meta-analysis. The blue bars, the blue lines, are the errors for those estimates that tell us how confident we can be about those estimates, and roughly are proportional to the size of the samples. And then you see the red diamonds, which give us an overall result. So these are the meta-analysis results, explaining what is the cumulative evidence in the meta-analysis. So what you can see here, if we start from the bottom, is that overall maltreated individuals are